Well, thank you very much. I'm Dr. Kevin Kavanagh from HealthWatch USA, and I would like to talk to you today about mitigating infectious disease risks during medical visits. During this presentation, I will talk about the risks of COVID-19, timing of appointments, preparation for the visit, waiting rooms, masking, ventilation, sanitizers and wipes, and vaccination. Now, the risks of COVID-19 have been understated by many individuals in our community, when in actuality, SARS-CoV-2, which is the virus which causes COVID-19, is more lethal than the flu. It is much more infectious, and in 10 to 20% of the cases, individuals will develop long COVID. COVID-19 also affects every organ of the body. As can be seen in this picture, the mouse on the right-hand side was infected with influenza, and primarily the lungs are the organs that are infected. With SARS-CoV-2, the infection, as shown in the mouse on the left-hand side, affects every organ of the body. It is not a respiratory virus. SARS-CoV-2 is spread through respiration, but once a person becomes infected, it doesn't necessarily act as a respiratory virus. It can affect the heart, the lung, the brain, cause diarrhea and affect the gut. And in fact, some patients have minimal pulmonary symptoms. Now, this is a graph from Epic Research. Epic is the large electronic medical record company, which is in the majority of hospitals and many doctors' offices. This is showing admissions from communicable diseases. The blue line shows those admissions from COVID-19. The yellow, those admissions from influenza. The green is from strep throat and the other respiratory tract infections you can barely see. But it can easily be seen that more hospitalizations are caused by COVID-19 than by influenza. So why is this? Well, there are three reasons. One is infections with SARS-CoV-2 are more severe than with influenza. SARS-CoV-2 is also more infectious, so there are more cases of COVID-19 than there are cases of the flu. And SARS-CoV-2 can occur almost any time of the year. It doesn't occur just during a few months in a year. And so all of this creates a situation where COVID-19 is a much more dangerous pathogen to our community than the flu. Now, before your medical appointment, you want to do all of your paperwork online. This is of utmost importance. Your goal should be to be in the waiting area as little time as possible. You do not want to be caught in the waiting room filling out papers while wearing a surgical mask. As shown in this picture, a surgical mask does not give you optimal protection. It has holes along the sides, which an aerosolized virus can enter. Timing of an appointment is very important. I like to have first appointments during the day. This is because there should be a lower viral load in the air. There's less time in the waiting room and less time waiting for the doctor in the examination rooms because the practice is probably not backed up with other patients. In addition, there has been time for the staff to clean the rooms thoroughly before the day begins. And if there were residual virons left over from the other day, many of these would have died. That is by far the best time for an appointment. The second best time for an appointment is in the afternoon because at least you'll be spending less time in the waiting room and waiting for the doctor in the exam room. If you go into the practice and the waiting area is crowded, give the receptionist your cell phone number and ask if you can wait in the car and be called directly back to the examination room. Now, if you need a semi-elective procedure, such as a routine colonoscopy, it may be best to schedule this procedure in May or June. These are the months when the rates of COVID-19 tend to be lower. As you can see in this graph, and this graph is of analysis of wastewater, with the exception of 2022, which is shown in green, all the other years had lower rates of SARS-CoV-2 and COVID-19 during the period of May and June. This year is shown in dark red, and as you can see, we're having quite a surge. So this virus has not gone away, and it is still dangerous. Now let's talk about masking. Masks are very controversial, but they work, especially two-way masking with N95 masks. And this picture shows two air travelers, both of which are wearing N95 masks in an airplane. Now this is a table from the Rockefeller and Colton Foundation, which shows the ability of different types of masks to reduce COVID-19 exposure in individuals. If you look at the second row, and these numbers are relative, they're not absolute, they're going to depend upon whether or not a person is infected with a certain pathogen and what variant of that pathogen they're infected with. So if you were wearing a cloth mask, you would have 20 minutes of protection, surgical mask 30 minutes, but a non-fitted N95 mask 1.25 hours. If both the recipient is wearing a mask and the source is wearing a mask, this protection jumps up to 6.25 hours, or 5 times the protection. If both the recipient and the source are wearing an N95 fitted mask, then this protection increases 10 times to 25 hours. Well, why is there so much more protection with two-way masking and universal masking? Well, one of the reasons is that when the source wears the mask, it interacts with almost every one of the virons which that source is exhaling. As when the recipient is wearing a mask, those virons or viruses can still infect and lay on one's skin, and a person can still become infected through their eyes. So you don't have complete protection. Masks do decrease the viral dosage you're exposed to, but they do not afford you absolute protection. Now, this study was published in The Lancet in 2020. They found that when face masks were used, the chance of transmission decreased from 17.4% to 3.1%. Likewise, when eye protection was used, transmission decreased from 16% to 5.5%. Again, the person who is the receiver can get infected both through their breathing and also through their eyes. And so this is really an important note that if you wear a mask, you're not 100% protected. You will have some degree of protection, but two-way masking or universal masking is most effective. Now, another problem is that the research studies which involve masks are very confusing. I like to look at studies being performed in two different settings. In medical settings, these studies often involve medical providers in medical facilities where there is a high viral load in the environment, and masks need to be used 8 hours a day, 5 days a week for the duration of the study, which is usually 30 to 60 days. Any lapse would cause an infection. And so these studies are very difficult to show an effect. Community studies are different. This is where viral load is smaller and exposure is intermittent. N95 masks, of course, offer better protection, and a very good community study was performed in Bangladesh by Stanford, Yale, and Johns Hopkins. So in summary, in medical settings, when masks are the only mitigation strategy used, they are difficult to show a protective effect, as in community settings, much easier. So let's talk about some two-way masking studies. A recent one, which was published in the International Journal of Environmental Research and Public Health, compared acquisition of SARS-CoV-2 between short and long flights. Long flights had a 25.93 or almost a 26-fold increase in transmission. That is huge. But what was noted, if masking was enforced, in other words, universal masking, no transmission was reported on long flights. So again, universal masking is best, you have source control, and it is very effective. Now, another study published this year in eBiomedicine in The Lancet, this looked at a group of individuals who were infected with SARS-CoV-2 and they wore a duckbill N95 mask, and they found a 98% reduction in the exhaled viruses, a substantial reduction. and that N95 masks outperformed cloth and surgical masks. And so this is one of the keys. You want to be wearing an N95 mask if at all possible. So let's talk about one-way masking. We briefly discussed the Bangladesh study, and I think that this is really a landmark study. It was actually a study involving masking education, not masking. Both arms masked. Only one arm was given education and encouragement on how to use the mask and that they should be using masks, and the other arm did not. There were 342,000 participants in both the control and experimental arms, and they observed an 11.6% reduction in COVID-19 symptoms. Now, many COVID minimizers and anti-science people will say, well, this study was a negative study. That's a small effect. When in actuality, that's not the case. Because remember, this was a masking educational study, both arms masked. There was only a 28.8 percentage point difference in mask usage between the two arms. Now, if all the subjects in one trial arm wore masks and in the other trial arm did not, you would expect the reduction in COVID-19 symptoms to be greater than 40%. And this would be even higher if N95 masks were used. Now, another study, which was recently published in the BMJ, observed a 27% reduction in self-reported symptoms between two groups of individuals, one group which wore a surgical mask, another group which did not wear a surgical mask, and they were allowed to go into public spaces. Now you can say, well, that's not a large reduction. Well, this is with surgical masks. It wasn't with N95 masks. And another problem with this study is a possible confounder, is that if all the people who wore surgical masks felt that they were more protected and thus they had greater risky behavior, the observed effect would be negated. So for example, if a mask had a 50% efficacy in reducing symptoms, but individuals that wore the mask because they felt overconfident, frequent bars and restaurants twice as often, it would eliminate any observed protective effect. So what I recommend with masking is use N95 masks. Bring several with you to your healthcare provider's office to encourage staff and the provider to wear them, and call ahead and to ask if the provider would wear a mask. And I order my masks from uline.com, which is a very old family-owned business in the Midwest, which has an excellent reputation. Now let's talk about ventilation. This is a picture of a portable CO2 monitor which I use. CO2 is used to measure and be a surrogate for good, clean air. Higher CO2 levels, dangerous air. Lower CO2 levels, a cleaner air environment. The data from this app is transmitted to my phone and it's recorded and can be displayed on a graph. As you can see, during this day, almost all of my time was spent in a clean air environment, except for one period of time where I was spending in an area that had over 1,200 parts per million CO2 levels. That's a very high level, 1,200 parts per million. And this was pretty discouraging because that was the time when I was seeing my medical doctor. That was when I was getting my medical appointment. So to put CO2 levels in perspective, outdoor air has 425 parts per million of CO2. Back in 1960, this was 320. This, of course, is one of the causes of global warming, building up of CO2 in the atmosphere. High quality indoor air, the CO2 should be less than 700 parts pre-pandemic ASHRAE standards. The CO2 should be less than 870 parts per million in indoor settings. Cognitive performance in thinking starts to decrease in the 900s. For example, there's a 15% decrease in cognitive performance at a CO2 level of 945 parts per million and a 50% decrease at 1400 parts per million. And that's one of the reasons why my doctor's office was dangerous at a CO2 level of 1,200 parts per million, not only because you may get COVID, but also because the doctor may not be thinking real clearly when he's giving advice, may forget something. Boston's Logan Airport consistently had CO2 levels below 600 parts per million. And as the room started to fill with people, I could feel their HVAC system coming on. Some of the HVAC systems have fluctuating ventilation depending upon occupancy and CO2 levels. And I think the ventilation at Boston Logan's Airport was extremely good. ASHRAE is the American Society of Heating, Refrigerating, and Air Conditioning Engineers. They have new pandemic standards out for control of infectious aerosols. It's called ASHRAE 241-2023. And these standards take into account the size of the room, the number of people in the room, and the activity of those people in order to determine what levels of ventilation will produce the safest environment. If you have a large number of people that are in a room where they're sitting down listening to a lecturer, you're going to be producing less CO2 and exhaling less air than, for example, if the same number of people were exercising in a gym. Now, this is a research study which was published in CDC's journal called Emerging Infectious Diseases back in 2020. The study was out of China and discussed an outbreak in a Chinese restaurant. The index case is shown here in yellow, and as you can see, a number of other individuals became infected. Many of these individuals were greater than 6 feet away. The reason for this is that the air was circulating within this area of the restaurant, and notice that there were even 2 individuals that were right next to the air coming out of the HVAC unit became infected. In other parts of the room that were not directly within this airflow, there were no infections, and likewise in the other part of the restaurant, there were also no infections. So airflow is important. Aerosolized viruses are a major concern with SARS-CoV-2. In April of this year, a disturbing article was published in the American Journal of Infection Control, and this reported 2 patients who were admitted to the hospital 2 and 5 hours after an asymptomatic SARS-CoV-2 carrier was discharged. And both of these 2 admitted patients became infected with SARS-CoV-2. So this virus was floating around and was still capable of producing an infection for 2 and 5 hours. So this is quite disturbing. And I should add that if this facility had adequate ventilation, even ventilation that provided 6 complete air exchanges per hour, these infections probably would not have occurred. So when I go see a doctor, I carry these items. I have an N95 mask, possibly more for the provider's staff. I have a CO2 monitor. I carry hand sanitizers and antibacterial alcohol wipes. Now these wipes I use on my armrests of the chair, if I have to touch a doorknob, or if I have to go into the doctor's bathroom or medical restroom, I can wipe down the fixtures. Now if you're at home and you want to wipe things down, use soap and water. Soap and water will not only physically remove the virus, but it will also kill the virus because the virus has a lipoprotein capsule and soap and water will dissolve this. And also some facilities are starting to add UVC disinfection. This is a layer on top of good airflow, and the sanitizing rates are phenomenal. It can kill SARS-CoV-2. These are safe. Some of the products, such as this one, does not produce ozone, and it's something that I would really encourage areas that have people that gather to start installing. Now let's talk about vaccination. As you know, during the beginning of the pandemic, we didn't know much about the virus. The vaccines were rushed to market, and many felt that, well, they were being experimented upon. But really, in actuality, you were either in the control group or you were in the experimental group, and those in the experimental group did much, much better. Now, one of the interesting historical notes about vaccines was in 1775, George Washington mandated vaccinations for his troops. Smallpox was very common. He felt it was highly likely he would have an outbreak of smallpox in his troops, and that this would decimate his fighting force against the British. Because of this, he mandated vaccination through the process called variolation, where a piece of pus-laden material was taken from an infected person and placed it into the wound of an individual to be inoculated. The fatality rate from this procedure was 5 to 10%, but it was far better than the 30% fatality rate from smallpox. Now, there are several lessons that can be learned from this. First, vaccine mandates in certain circumstances can be necessary and they are not anti-American. Second, a vaccine is not free of complications, but you are less likely to develop these complications with the vaccine than if you're not vaccinated or with an infection. The premise behind vaccination is to give an experience to the body of a mild infection, which avoids most of the complications but imparts immunity, and oftentimes boosters are needed. Now, this graph was posted by Cambridge University in their website, Our World in Data, and it shows the death rates in individuals who had and who did not have a COVID-19 vaccination. As you can see, those who were unvaccinated, shown in yellow, had a far higher fatality rate from COVID-19 than those who were vaccinated, which are shown in blue. And those who had boosters had even a lower death rate. However, even though deaths have decreased, the problem of long COVID is still persistent and is starting to incapacitate our workforce. And vaccines are by far our best protection against getting long COVID. In a meta-analysis by Mara and colleagues, they found that individuals who received 3 vaccine doses were 69% protected against acquiring long COVID. In a recent study by Lundberg, Morris, and colleagues, they reported a stepwise reduction in long COVID as the number of vaccine doses increases. There was a 21% reduction after receiving 1 vaccine dose, a 59% reduction in long COVID after 2 doses, and a 73% reduction in long COVID after 3 doses. Now, unfortunately, if you are immunosuppressed, things are a little bit more complicated and difficult. It's best, for example, if you're going to have a transplant, to be immunized before the transplant. This, I think, is extremely important. There has been at least one study that found that for those who have been vaccinated before transplantation, that they maintained superior immunity. Now, if you've already had a transplant, you still should become vaccinated. However, you may require additional boosters, and you should always have your antibodies measured afterwards to make sure you've had a good immune response. Often, there is suboptimal production of antibodies, and additional vaccine doses may be necessary. Antibodies can be either at low levels or could have too narrow of coverage for neutralizing variants. Live attenuated virus vaccines should be used with extreme caution in transplant patients or immunosuppressed individuals. However, there are no live attenuated COVID-19 vaccines. Now, if you do not develop an adequate response to vaccination, another option is passive immunity with PEMGARDA. PEMGARDA is a monoclonal antibody product, and it can neutralize the JN.1, KP.2, and KP.3 strains of the virus. However, it has almost a 33-fold less effectiveness against the KP.3.1.1 strain, which you can see in the figure on the right-hand side. It is currently becoming the predominant strain in the United States. Now, I would like to thank you for inviting me to present this information to you. I would like to close with this caveat, which has been posted on the CDC's Clean Air website, that not providing a safe environment for you to receive health care in may well be a violation of your civil rights as outlined in the ADA. It is your right to receive medical care in the safest possible healthcare setting. Thank you.